For the last 18 or so years, Kenya has been on a trial and error phase, trying to work things out on universal health coverage. Well, what exactly is this concept and how does it work? Even as we hurtle towards the year 2030, where Kenya has set the target to ensure there is UHC for all the citizens in the Republic of Kenya. What have been the hits and the misses? And what lessons can we learn from the past and the mistakes that we have done and avoid them in the future, even as we embark on the rollout of UHC in Kenya? Today, one of the big news that we are watching out is the signing of UHC bill by President William Ruto at State House. Of course, we shall be live on that very critical point in the afternoon. So you better keep it right here. And of course, I have a team of experts in the studio who will be helping me understand this whole concept of UHC. Where are we in terms of the rollout? What is the role of the National Assembly? Of the national government, as well as the role of county government and private sector players. That is a conversation that is coming up here in the next 3 or so minutes. The other issue that we shall be discussing here is how to tap the North American markets. Let me give you some statistics. When you look at the North American markets, you're talking about a market that is more than $500 billion in terms of travel and tourism. It's the biggest in the world, it's the most lucrative. And when you look at the number of Americans, tourists who are coming over to Kenya, it's a drop in the ocean. And so what do we need to do to tap this critical market? What strategies have we put in place to ensure that Kenya becomes attractive to the American traveler? And mind you, the American traveler is the most lucrative in the world. And so if you get the American market, that is the North American market, Lord, oh Lord, you've got it all. So we shall be having that conversation right here. You know this is BizCheck. And you know that we are live from Broadcasting House. My name, as always, is O'Brien Kimani. I'll be taking you through these conversations for the next 2 hours. And we also have our reporters on the ground. We are keeping tabs of the conversations that are taking place at the Deputy President's office. He's meeting coffee stakeholders, and the conversation there is how to bring to fruition the reforms initiated in the coffee industry. We'll also be listening to what the Minister for Lands he's expected to address the nation on matters, the ongoing demolitions in Mavoko sub-county in Machakos County. Well, what will he tell the world? That is the conversation that we are keeping tabs here. My name is O'Brien Kimani. And let's now get straight to the point. The conversation this morning. We are starting off with UHC. And we just want to understand what is this concept around UHC that Kenya keeps on talking about, and why the United Nations is very much involved and worried about the state or the status of healthcare in developing world. To help us in this conversation, we're joined by Dr. Abdallah Zirago. He is a research scientist at the African Population and Health Research Center, APHRC. He's joining us this morning. Thank you very much indeed, Dr. Ari.
Thank you for having me.
Very good indeed. And just next to Dr. Abdallah, we have Edwin Kegode. He's a general manager for managed care at MINET, which is a local health insurance company. Thank you very much indeed, Kegode, for joining us.
Thank you for having me.
I want to start with you, Dr. Abdallah. When we talk about universal health coverage, what exactly are we talking about?
Yeah, in brief, it's really an undertaking where countries commit to ensure that their population, all their populations, receive a certain minimum of quality health care when and where they need those services without encountering financial barriers at the point of receiving the services. It doesn't mean free services, but avoiding the situation where you are not able to get services because you don't have the money on you.
So you're talking about two aspects of this. You have accessibility and affordability on one end. At what point do you get as a nation to say we have succeeded on accessibility?
Yeah, there is something we call coverage, meaning that there are indicators, a number of indicators which we measure to say how many of the people who should be receiving this service have been able to access this service and used it. For example, if you're looking at skilled birth attendance, say how many women have given birth with the support of a trained healthcare worker. So accessibility is both in terms of the service, but also the enablers to get that access, because services are not free. Somebody is paying, whether it's government, whether it's out of pocket, whether it's a family, whether it's an employer. There's some kind of process going behind to buy that service. Yeah.
And when we talk about services that are offered at the accessibility level, we know there are simple services and procedures, and there are technical procedures. For example, the technology today in the world of surgery is laparoscopy. It's completely different from the traditional knife process that we have always known. So does it mean that in terms of accessibility, I also have to get the most updated technology available in the world?
Yeah, I think from the health services perspective, we want always to give the best to our people, to our patients. But we also know that circumstances are not the same. You may not be demanding what somebody in New York is demanding. So the concept around UHC rides on the principles of primary health care. That the services are accessible, that they are affordable, they are acceptable, and they are effective. So UHC doesn't envisage that you're going to get the most recent technology intervention on the market, but what is affordable within our means, and that has been scientifically proven to be safe, to be effective. Because you might have two interventions, one an old intervention but it does a good job, and another one new technology but probably unaffordable. It will be quite foolhardy to insist that you want the most recent. If a knife is going to remove that appendix by opening your tummy, and your doctor has not been trained in laparoscopy, you should be good with a knife.
With a knife?
Yeah.
I'll be coming back to you, because what I'm getting from you is that universal health coverage is different from nations. Is it true?
I would say the best concept is that people should receive the service they need.
The services they need.
They need. And
not the services that are available.
Yeah, exactly. Because you might have services that are probably not what you need. And because you're just able to pay, you might be demanding for services that you shouldn't be demanding for. I lived in the UK for some years, and I can tell you how difficult it is, for example, to get a CT scan or MRI done on you.
A CT scan?
Yes, and yet it's a rich nation. But because of their conceptualization of their healthcare delivery, you don't just walk in there and say, "Doctor, can I have a CT scan?" There must be a thorough vetting of why you need this. And eventually that speaks the issue of affordability in the healthcare system. And I keep asking myself, the way we deliver services, the way we demand for services, is it affordable if you are looking at reaching even those who are not able to pay for services? So affordability is always an important point when you're looking at accessibility. Yeah.
Kegode, help us understand this. I mean, when you look at the last 15, 18 years, I mean, that Kenya has been trying to roll out UHC. Would you see that we have covered any grounds yet?
Thank you for that question. I think Kenya as a country has been walking this journey of UHC right from independence, I would say. And indeed, there's been great milestones made towards realizing universal health coverage since the promulgation of the 2010 Constitution. I think there's been deliberate efforts to enhance service provision, and one of the tenets of UHC being access to healthcare services when you need them, and also an underlying factor being that one should not experience financial hardship in the process of accessing health services. So indeed, I would say there's been great milestones. There's still some ground to cover, a lot of ground to cover. And I think the bills that are before, that have been in Parliament and which the President is going to assent to, are in an effort to solidify that position of provision of UHC.
When you say that there has been great milestones that have been covered, what milestones are these?
I think the most recent that we can refer to is the pilot program that was run by the government in an effort to understand the situation on the ground.
The one that was rolled out in 4 counties?
Yes, in the 4 counties, yes. That was an important milestone in terms of being able now to go on ground and deliver these services. Abate the challenges that may have been there. I'm sure there have been great lessons learned through those efforts and those initiatives. And I would indicate that possibly is providing the knowledge base upon which the next round of UHC is going to be built.
But we do not know the progress or the failure of that pilot program that was rolled out in 2018 by the former President Uhuru Kenyatta. So how do you qualify that to be a milestone?
I think for you to be able to offer a service across the Republic, you need to run a pilot program which enables you to get to learn the different scenarios that prevail across the country. You're able to establish costs, you're able to establish the behavior patterns, you're able to establish the availability of services on ground, and therefore I would infer that pilot should have created a basis upon which UHC can be anchored. When you read articles and you read researches, yes, indeed, I would say it may not have achieved 100% of the expectation. But as we were just discussing with my friend here, is that no research is futile. Yes.
No research is futile. When you're still at it, I also want to hear from you. You see, when you look at the Kenya, at the universal health policy that was launched in the year 2020, it talks about reducing the out-of-pocket expenditure on Kenyans from an average of 43 shillings, out of every 100 shillings, to about 20 shillings. But when you look at the situation now, where we are, because of inflation and other factors, this has actually gone up. You're talking about 50% as we speak now. Would we say that we are making any progress? I want to hear from you as a researcher.
From the available data, and especially from the global bodies like WHO, it's clear that there was progress before 2015. In terms of coverage, if you look at most of the indicators, they were going up in terms of coverage. Out-of-pocket was also reducing, but there is a clear indication that after 2015, coverage has stagnated, meaning that if you look at an indicator like, for example, service coverage indicator, compound indicator, it's around 52%.
52%?
Yeah, 52%.
So which means that for every 100 shillings that you earn...
No, that's for coverage.
Oh, now for coverage.
Yeah,
oh, okay.
For catastrophic out-of-pocket expenditure, about, if I remember correctly, about 5.8% of the people in Kenya experience catastrophic expenditure out-of-pocket.
What is that?
That means if you are earning 100 shillings as your income, you spend more than at least 10% of that money on health. The recommendation is if you spend in a normal range, that expenditure shouldn't be beyond 10%.
It should not be beyond 10%.
Yeah, a lot of people are spending more than that.
This is the global standard, or is just a standard for Kenya?
Yeah, this is a global standard that applies to us because the contexts are different, but what is inbuilt in that matrix relates to Kenya in all ways. And we subscribe to that as the indicator for tracking our progress. And I wanted to say something at the beginning, that at times we look at UHC as a destination, but I think sometimes it's better to look at it as a journey.
As a journey.
As a process, because...
But every journey must have a destination.
Well, yes, that's true.
Because you can't journey forever.
Eventually people at times get disillusioned. Why are we not getting there? Because even rich economies are still struggling to get to the 100% coverage. There will be people who will fall through the cracks a bit. So it has to be known that this is a journey. And when you look at the principle of continuous improvement, we need to continually improve in the coverage. We need to continually improve in protecting our people from catastrophic expenditure out of pocket. And out of pocket is not just for the poor. If you and me, I'm sure you're not poor,
well, I don't know that.
have to pay from their pocket when they fall sick. It's quite a high-risk undertaking, because you might fall sick on this day when you don't have any liquidity on you. So the recommendation is we should be protected to a level, to the extent that we should not be denied services just because we don't have the money at the point of receiving care.
That's very true. And we are lucky enough to have an underwriter in the house to help us understand. Why is it that, insurance services or medical insurance remains beyond the reach of more than 95% of Kenyans?
That statistic is scary to the populace.
But is it true?
Yes. A good number of the insured population are the persons who are in formal employment. Mostly, you'd find persons in formal employment.
And they are the minority in Kenya?
Yes, and they're the minority in Kenya. And so a larger population is out of pocket, and in the recent past, some of them have been able to subscribe to the National Hospital Insurance Fund, which is now undergoing transformation. So the reason why you find fewer of the population being able to afford healthcare services is that healthcare premium rates have been on an all-time high. However, we are seeing a lot of innovation coming in, whereby we are embracing different health financing models, one of which is becoming quite popular is the capitation model, which is allowing the cost of care to be managed at a lower level with proper negotiation with the end service providers, which is the medical service providers, and in so doing, making it reasonable to afford healthcare services. So I can say the preserve has been mostly for the employed population and high net worth individuals, but there's also been innovation in the space of microinsurance, where we can see that many other players are coming in to provide solutions for farmers, for organized groups, where they can pool together their resources and be able to secure a form of health insurance. So the space
what are the numbers now talking about? I know, according to statistics from the Insurance Regulatory Authority, they have always said that insurance coverage in Kenya, is below 4%. For the longest time, it is stagnated at about 2.5%. There has been a slight improvement, but you can't say that is progress when more than 95% of your population, are not covered by any form of insurance. So what does innovation has to do with these? And then what do we need to do to reduce the cost of premiums in Kenya?
Okay. The statistic that you've cited by the Insurance Regulatory Authority, that the insurance penetration is below 4%, yes, it is a true statistic, but that statistic is against the gross domestic product, against the GDP. So it is looking at the value of insurance against all other...
it's not based on abstract population?
No, it's not based on abstract population. But when you look at some of the statistics that you alluded to, about over 80% of the medical insured population is under the National Hospital Insurance Fund. And the other 20% is within the private sector, private medical insurance. And so for us in the sector to be able to increase the accessibility to medical insurance services, we have embraced models that would cut the cost of care to a minimum, and therefore extend this benefit to members by way of providing affordable solutions. So one of which I have highlighted before is capitation, whereby we are able to negotiate with medical service providers to give rock bottom rates, bearing in mind the economies of scale by the sheer volume that we're able to place with them, and that benefit is then extended to members where then they can be able to afford insurance. Yeah.
Very well. I mean, if you're just joining us, we're having this conversation around the universal health coverage in Kenya, the milestones covered, the hits and the misses, and what we just need to do to ensure that we get it right. And the target is to have universal health care in Kenya by the year 2030. Today, President William Ruto is expected to assent to 3 critical bills and that are expected to drive the achievement of this. And and the 3 bills are the Primary Health Care Bill, the Facility Improvement Financing Bill, the Digital Health Bill, and the Social Health Insurance Bill. All these bills are expected to drive and to deepen the universal health coverage here in Kenya. They have a lot of excuse me. They have a lot of goodies, but we are discussing them here and asking ourselves, how do we improve on this? And we're in the company of 2 experts. We have Dr. Abdallah Ziraba. He's a research scientist at the African Population and Health Research Center, as well as Edwin Kegode, who's a general manager for managed care at MINET Insurance. Thank you very much. Let's go and have this conversation going on. Dr. can you help us understand, first of all, these 4 bills that are before the president? How critical are they in the implementation and rollout of UHC in Kenya?
Yeah, thank you. I think it's good to state up front that healthcare is expensive.
It's expensive?
Yeah, it's expensive.
Is it expensive by design or by default?
By default. Whether you're looking at the big economies, healthcare is expensive. A lot of Americans are not covered, and that's a fact. So these bills are supposed to be pushing the pilots that we saw being undertaken in the 4 counties to maturity in terms of the scope, but also in terms of involving all the other counties in the rolling out of UHC. So for me, in summary, I would say these bills are enabler. They're kind of contributing to what needs to be done. I mentioned that healthcare is expensive, and one thing that we need to do is to diversify the sources of funding. You might be familiar with the Abuja Declaration that mandated or required countries to spend 15% of their GDP on healthcare.
Is it of their GDP or budget?
Of their budget, yes.
Annual budget,
of their budget. And up to date, hardly do we have, probably 1 or 2 countries have gone beyond 10%. So that's really a big challenge.
And Kenya is not one of the 2.
No, it's not one. Yeah. I'm very sure about that. So if you look at a bill like the social insurance one, it's really looking at how do we get more Kenyans into insurance. I was chatting with him earlier that a lot of people who can afford insurance are not insured because of the very design of insurance. If you're not in an organized kind of employment, you're sort of considered to be high risk, and you might be having the means to pay. But because you're not in an organized group, insurance is about pools. They want to work with pools. That's how they mitigate the risks and make a profit. So if we go the route that the bills are proposing, where a lot of people are going to be signed on, I think we'll have a chance of having a bigger pool of financial resources, which can then be used to purchase services, because it's all about resources. But the other important thing about the future is the issue of governance. You might have the resources, human, financial, infrastructure, But if you don't have good governance, then you have a problem, because resources might be misused. Officers who are in charge may not be accountable because they know there are no consequences if they don't perform.
Yeah.
And I'm yet to read these bills, but I think the intention is really to draw the lessons and take these forward in terms of ensuring that Kenya can have bigger steps towards achieving UHC.
Mm-hmm. Yeah. And I like the fact that you're bringing in the issue of governance, because it is true, you may have the best technology in the world, you may have the best hospitals in terms of infrastructure, right. But if governance is not right, then you're likely to end up, right. Not getting it right. And this is why I want to hear from Kegode. I mean, in 2012, Kenya introduced a two-tier government system where we have the national government and we have the county government, 47 in numbers. And at this point, we devolved the health services, and now health services, became the concern of the county government, and the national government was left with formulation of policies and budget. Was this a good move, really, when you listen to all the challenges that the health sector is facing at the county level?
You pulled me into the politics of the day.
Well, I don't want you to touch on the politics of the day. I just want to, just want you to look at it, as it is, and then make your suggestions based on that.
Yes, indeed, Kenya has gone through transformation in the governance, and where we have the central government and the county government. I think in the wisdom of the drafters of the Constitution and the implementers of the Constitution was that health services are best offered closest to where people reside and where people live. And since devolution was one of those means of getting services to members of the public, then health services were devolved under that framework. And so I think in the wisdom of the drafters, as I said, and the experts, that would be the best way to roll it out. However, these challenges that you've cited that possibly bedeviling the health sector, I am sure that the government or the persons who are in position would be best placed to be able to address whether it is the best model or not. However, just looking at the bills that you've talked about, one of the key bills is the facilities improvement financing bill. Mm-hmm. And this is geared towards ensuring that health facilities are able to retain the revenue that they collect for the various services that they're offering. Mm. And I think from where we come from in the insurance sector, public facilities have not been roped in their large numbers into health insurance framework. Mm. And I think it was mainly because these revenues would be collected and sent to the central kitty. Yeah. And then they would be able to make requisitions for any purchases that would like to have, any procurement. Mm-hmm. So by ensuring that these funds can be kept at the health facility would hasten being able to procure emergency services or emergency goods that would be necessary for provision of health services. So I think just looking at the 4 bills that you mentioned, mm-hmm. that is one of the bills where insurance would be able now to properly work within the government facilities, which I would say as MINET we've been able to endeavor to onboard or contract quite a number of government facilities to enable us to provide health mm-hmm. insurance services. And that is part of the reason why I said we are now in a position to provide affordable insurance services to members because of incorporating government facilities. So I think for the larger insurance sector, this is a great move because hospitals will have the impetus to be able to sign up insurance programs because they know that the remuneration or the reimbursements that will get through insurance would come in to assist improve the health facilities.
When you look at, for example, the allocation to the health sector, at the county and vis-a-vis the national government level, You're looking at about 6.8%, at the national government, and about 4.5% at the county levels. And so you see this level of mismatch. And all of us, are moving to the same direction. But this mismatch, do you see it affecting the achievement of UHC, Dr. Ari?
Yeah, in my opinion, devolution or decentralization in other countries, as they call it, I think is good for service delivery because then the planning and the knowledge of what is a priority is best known at the source. So devolution is good, I think, for service delivery. But there are areas where we may need to think a bit more critically of what roles needs to be at the county and what roles need to be at the central government, that's the Ministry of Health. And one of the things I think that has really challenged the counties is the human resource. Human resource for health is also not cheap. If you need adequate numbers of well-trained workers, you need to pay them. And given the allocation that you've just talked about, I think they have struggled to attract and retain adequate numbers of service providers. So maybe we should be entertaining a conversation of what other functions need to be considered or to be supported by the central government, especially when the central government is retaining a bit of a substantial amount of money allocated to health. So in some, devolution is good, but the allocation of resources and the division of responsibilities and who gets what, I think that's where they say the devil is in the details. So that's where really we need to be focusing on.
So how do we unravel that mystery and deal with that kerfuffle?
I think devolution is still being, in some way I can say, it's being still understood in Kenya in terms of how it should be operationalized in the different sectors. So my point would be to continue having the conversation around what would be the best way of facilitating the implementation and the provision of services at the county level. At the highest level in the government, we had, and actually the political discussions, we had conversations around how much money is going to the counties. Of course, that includes health service provision. So maybe if the sitting government, parliament and the Senate, if they can entertain some kind of more discussions around what more needs to go to the counties and which sectors does it need to go to, maybe that might be a contribution towards the right direction. Yeah.
And when you look at it, what recommendation would you make?
In terms of the general improvement of UHC? I think if you were to make resources available in terms of pooling, there is no way of avoiding insurance, whether you're looking at the private insurances, whether you're looking at social insurance. I think we need to be able to pool resources. When you pool resources, you spread out the risk, right? You spread out the risk to the extent that a few of the people who are insured who get the condition are able to get the services they need, and the insurance also remains with some profit margin to be able to keep in business. So we need to pool resources. And the two, when those resources are pooled, we need to be able to purchase resources in a transparent way. And Kenya is making big strides in terms of digitalizing some of the processes, because when you make things digital, they are traceable, meaning that you reduce fraud, you encourage openness, even among providers, whether service providers or insurance providers. And then the other thing we need to do is to improve the quality of services. Because if an individual has subscribed, has paid a premium for insurance, they need to go to a national hospital or a regional government hospital and they get the services that they ought to be receiving in terms of quality, in terms of the way patients are treated, so that they feel that they are getting value for money. Because I think that has been part of the problem, especially with government facilities where people who are willing to pay and able to pay are reluctant to go to those facilities. I don't know when you were last in a government hospital.
Let's ask him. but before we even ask him, before he responds to that question, look, And I like the fact that you have lived in the UK, and so you are at a position whereby now you can do a proper analysis, between the health cost in the UK vis-a-vis here in Kenya and the services offered. And I want to ask you this. You talked about PET scan. It's a complicated technology. Right. It's a bit expensive here in Kenya. I don't know whether you have the numbers. How much will it cost to do a PT scan here in Kenya vis-a-vis in the UK?
I don't have the figures on top of my head, but definitely it's much more expensive to do anything in the UK. It's much more expensive, yes. But
how comes a lot of patients, they end up being sent to the UK?
Because those ones who are sent are able to pay. Somebody from your village has been sent to the UK to do a PET scan. You can't afford.
It's expensive.
Yeah, those who go are able to afford.
Mm-hmm. Yeah. And you are saying, you're talking about, health services being expensive, and you say this is by default.
Right.
That's what you said.
Right.
Is there anything that can be done to lower the cost of health services?
Yeah, I talked about the issue of pooling resources. Insurance, if we think and agree that insurance is the best way to buy services, what they need is a pool resource sort of pot where many people are subscribing. Insurance works with numbers. The more people subscribe, the more they can offset their costs, and they are hedging on the fact that the events will not happen. So if they recruit 1,000 instead of 1 million, they are not really operating optimally. That's one. We need to increase that pool.
But you also recognize that, would you say that, the Kenyan insurance market is overly saturated? There's too many players, chasing a very small market.
Yeah, the truth of the matter is, where there is competition, Kenya is a free market economy. Mm-hmm. Where there is competition, those who are not fit should die and leave those that are able to survive to continue providing the services. That's a natural selection thing.
It's a highly capitalistic sentiment.
Yeah,
huh? I want you to comment on what he's saying. That there is beauty, when you pull your resources together, when you come together, and when you do what we call consolidation. And when you look at the Kenyan market, I don't have the latest numbers, but we have more than 30 insurance companies, right?
Yes.
Serving a population of about 60 million people, where insurance penetration is less than 3% of Kenya's GDP. Is it high time then we started talking about mergers, acquisitions, consolidations, and buyout?
Indeed, just to maybe, as you said, respond to one of the sentiments he made, is that currently PET scan, as a question that you had put forward, yes, is available locally, and I think the average rates are about 60 to 70,000. We have two major hospitals in Nairobi who are offering that. I'm yet to hear of any other: the Aga Khan University Hospital and the Kenyatta University and Teaching and Referral Hospital, where PET scans are now available. So the need for...
Aga Khan is a private hospital, Kenyatta is a public referral hospital.
Public referral hospital. So that gives you...
And the charges are the same?
Relatively,
are the two institutions?
Relatively within that range that I provided, 60 to 70. But the more important thing is to say that Kenya is making progress towards bringing some of these technologies locally. And that is an advantage to our members, because from the insurance sector, we've had quite a number of people being sent out of the country to seek diagnostic services like the PET scans. Now that they're available locally, that helps us to retain our money locally, and also increase the capability of many more other providers in bringing that technology locally. So going to the issue of the penetration of insurance versus, I think the question was penetration versus what do we need to do, really, to make insurance continuously available to members, despite the large number of insurance companies we have. I think innovation is the way to go. And innovation, what I would say, is embracing technology. The reason why we've continued having the administrative costs of insurance on the high is because many companies have been, using traditional models of operation. So embracing modern technology to cut down the administrative costs, which you can push back as a benefit to reducing the premium that are payable by members. That will be a good step towards making it affordable. Having the large number of insurance companies is not a problem. It actually avails choice for our members. Members of the public have choice where you can be able to assess your affordability of insurance services versus your budgets. But the subject of mergers and acquisition is a live subject. We've seen quite a number of insurance companies coming together to consolidate their books and be able to offer the services. And this is one way to increase capacity to underwrite larger volumes of insurance. Another model that is embraced in the current scenario is what you call a cooperation of insurance companies. I would say MINET is at the forefront of consortium leadership. And we see that in the various solutions that we provide to our members, we have brought together 3, 4, or 5 insurances to be able to consolidate their capabilities and their capacity to offer services to many large population. So having large number of insurance companies is not a problem. It's just finding mechanisms where we can work together to offer these services to the population. So consortium frameworks are the better way to be able to defray some of these costs and reduce our administrative costs and pass on that benefit to members.
Dr. in the interest of time, because I can see that we should be coming to a close in the next in the next 90 seconds from now. What advice would you have to policymakers and policy implementers for us to get it right in the rollout of UHC in a seamless manner? And are there examples of countries that have managed to roll out UHC and that we can emulate? I know Cuba has always given us a very good example. Then do we need to go the Cuban way?
Yeah, you asked me about what we need to do, and I talked about insurance and the issue of buying services. But it's not just about the cost. It's also the modus operandi of how we deliver the services. You talked about the innovations. How do we innovate, cooperate to reduce costs, to detect and reduce fraud between claims, and the point I want to end with is the issue of going back to the ethos of primary health care. In most of the African countries, I think we're spending a lot of money on curative services. Whereas
on curative
services, we need to be preventing diseases before they happen. We need to be promoting health. We need to be treating those that need to be treated using the appropriate technology and interventions. We need to be rehabilitating people who need the rehabilitation. So if we go back to
preventive,
promotive,
measures.
Preventive, and then you can now talk about treatment. And I think we've not been doing well on that front.
Very good.
A lot of focus and investment in treatment rather than prevention.
So the whole point is we need to stop diseases before they happen,
Instead
of employing curative measures. Thank you very much indeed, Dr. Thank you, Kegode, for finding time to be with us, and of course for sharing that with us that insight. Well, you're watching this check live from Broadcasting House. I told you that the first hour we were discussing the UHC. The second hour we're looking at the tourism market with a keen focus on the American market. I told you it is one of the most lucrative markets in the world. We just want to see how do we tap into this market and ensure that we have more American visitors coming to the Kenyan market. This conversation is coming up in the next 5 minutes or so. So you all better stick right here. My name is O'Brien Kimani. You're watching the Score. Biz Check. We are live from Broadcasting House. Stay right here.